My name is Anna Gomez. I'm the Director of Public Health for the Yuma County Health Services District, and I'm going to be joined today by my team, our vector control staff, Richard Cummings and Joey Martinez will be joining me today. I want to thank the Arizona Department of Health Services for this opportunity to be able to share some of the lessons we learned while we addressed a dengue outbreak along the U.S.-Mexico border. So I'll just wait for that to pop up, a little presentation. And I'm so glad lunch was right before, because I didn't want to be the person standing between you and lunch. That was like my biggest fear. So now that everybody's settled, so let's see if we could put the PowerPoint back up. All right. So I introduced my team. Again, Yuma County is located right there on the southwest corner. You can't see our little star, but you can see that our county has to address multiple issues, cross-jurisdictional issues. We share a border with Mexico, and as you can see, it's a very busy border crossing. We have binational implications. We share a border with California as well. The county sits along the Colorado River. We have the Cochin and the Cocopa Indian reservations within Yuma County boundaries. We have 2 military bases. We have the Yuma Proving Grounds and the Marine Air Corps Station. So it's very busy, a lot of travel. Our border crossing, we see an average of 22,000 border crossings per day, which roughly translates to about 8 million crossings per year. So when we were talking about infectious disease and you see what the activity looks like, and then in the wintertime, we also have an influx of winter visitors that are fleeing the northern areas of the country, looking for cooler or warmer climates during the summer. So our population almost nearly doubles during the winter time. So again, that poses some serious challenges in reference to communicable disease and tracking things. As far as our military bases, we have a lot of contractors coming through in addition to the people that are stationed permanently on base. We also host a series of standing training exercises where we have military personnel coming from different parts of the country to join us for that. So back in 2014, what we started seeing, it started with a newspaper article, actually. It was a newspaper article from the Sonora newspaper that pointed out that they were starting to see some dengue cases in Sonora, Mexico. So at that time, it was only 5 cases. So what that did for us in our radar was, okay, this is something we need to consider. We had never had any dengue cases. It wasn't anything that was remotely on our radar. Our clinical providers, our hospitals, our clinicians had no reason to consider that as a diagnosis. So what we started seeing was that number go up. So what we did, the first thing that we did was we had to figure out how to get that information to our clinical providers and how to make them aware that perhaps it was the middle of flu season, how you can start thinking about other diseases, particularly dengue, which just seems so far off anybody's radar. So you're starting to see people that are displaying, symptoms like muscle aches, fever, typical flu-like symptoms. So we rapidly started seeing that number climb. And as you can see, right on the left, you can see the cases that manifested themselves or that were actually identified along the Mexico border. And if you look to the right, you can see that that's what we saw. We ended up going from 0 cases ever to ending up the year with 71 lab-confirmed cases. So it happened pretty fast. So how do you begin to address something that you really have never had to deal with before? So the key here was to have a truly coordinated approach. So at the local level, what we were responsible for as the county health department was the local response. What did we want it to look like? Who were our key stakeholders going to be? What kind of surveillance? How are we going to enhance our local surveillance? Most of all, that outreach, that vital outreach to our clinicians, because those are the people that we're going to start seeing, the patients come in through the urgent care. And a lot of times, like it was mentioned before, people don't go to the doctor for those symptoms. They take, a fever reducer and they stay home. So getting that information out there. And so we really didn't have a lot of that readily available. So here comes the state portion. And as Dr. Chris said earlier, actually Arizona has an incredibly strong public health infrastructure. I've had the privilege to work with the state health department on several projects, and it's always reassuring when we go somewhere else to really see how that advanced planning we are so far ahead of the game in so many instances, and that's because of that foresight and the planning that goes into place for things that we, as a state, that the state anticipates that we haven't even begun to address yet. But I'd like to reinforce that message that was said earlier. You are in good hands. The level of preparedness and proactive measures that have been taken are very impressive, and that was verified when we recently went to the CDC-hosted Zika Summit. And I remember being with my colleagues and the state health department at a breakout session. And they were asking, we were with different states, and they were asking about what we were planning to do, what were our first steps. And Jessica Rigler, I'm going to put her on the spot, but takes out this big binder and says, we've been planning for not only months, but years. We have these work groups, and we have these plans in place. And so Dr. Chris' team has really been doing a very impressive job of staying ahead. And so we are, regardless of the risk level, the preparedness is there. So that's reassuring. So we definitely reached out to them, and they provided vital epidemiological support as well as technical assistance. Also, their Office of Binational Health was a critical link in helping us communicate with our binational partners, our counterparts in Sonora, who were experiencing the same situation across the border. Then there was the federal piece, and Dr. Jones is here who led our EPI team. Again, very important epidemiological support and field training. So I'll talk a little bit about that dengue aid that happened, but what was really critical for us is my staff, my vector control staff has been working in vector control for over 20 years each. And what they learned out in the field by shadowing and interacting with the CD team was invaluable, and I think they'll share that a little later on. And again, that binational collaboration. Like I said earlier, we have 22,000 crossings per day, 8 million per year. So a survey, one of the things that happened during this investigation was surveyed people about how frequently they visited Mexico. And over 80% said it was on a regular basis. So it just happens every day. So what were our priorities? So we had to figure out where to start. And so our priorities basically at our first level was we wanted to make sure that the clinicians were aware of what was happening across the border, and to know that a lot of these patients sometimes seek medical care across the border. What we have in Yuma County is we have a lot of employers that offer dual insurance, and I don't know if that happens anywhere else, but many of our employers provide an option where you can get your regular insurance, whatever your insurance provider would be here, but then you also get a supplemental insurance where you can go to Mexico and see a physician that's in their network. So a lot of times, depending on the co-pays or what the cost is involved, people choose to be part of that network. And instead of paying a higher co-pay here, they take advantage of that system and they go seek medical care out there. So what we wanted to do was we wanted to make sure that clinicians here knew that perhaps we would see patients that would be coming over to the emergency room if they had complications, or the outpatient clinic, or just the regular physician's office. And we wanted them to consider dengue as a diagnosis. So it was getting that information out. Then, of course, the case investigation. We needed to know, where the cases were. We needed to be able to identify if there was any clusters. We needed to be able to follow them up. And so we needed to have communication with our EPI partners in the local hospitals and all our sentinel sites that report to us to make sure that we had that information. Again, the public education and outreach is critical. Dengue or Zika, these are things where public health is going to lead the role, but it's really up to the individual. It is really up to the public to know, to be empowered, to know what they need to do to protect themselves, protect their families, and protect their communities. We had an issue come up earlier. Somebody asked a question about going to private property and the pools, and we can't go into every backyard. We can't assess that risk. It is up to the individual to know what they need to do and take those steps. And that's where you change that with public education and information, because it's empowering. It takes that fear of, I don't want this to happen to me, to what can I do to protect myself and my family. So the community engagement was very important, addressing these issues with our local stakeholders. So we reached out to, for example, Parks and Recs, the local municipalities, the governing entities, to let them know that this is something that was in the horizon. And although we were only seeing a few cases, we anticipated, because of the way it's transmitted, that it could rapidly escalate. Then the next step was mosquito control. So one of the things that we were working on was working with our department to identify a GIS application to be able to track not only where these sources, breeding sources were, but what kind of abatement, what kind of treatment was used. And again, coordination and strategic alignment. So there's a lot of resources out there, and so a lot of times what we do is, as independent agencies, we work towards abating an issue or addressing an issue. So how did we as a community come together, or how could we as a community come together to align those strategies and address the issue from multiple angles? So that coordinated approach again, let me see, I'm going backwards. So we started with the provider education. And so what we wanted providers to know was we wanted to have them ask just routinely now something that they normally would not, which is, what is the travel history? We wanted them to be able to have patients that came in and assess them for their travel history and whether they had been to any of these places where we were seeing this dengue outbreak. So we had them sign up for alerts and bulletins. Our preparedness program also sent out a series of regular messages. We had stakeholder meetings. We issued out fact sheets, and then again, when the EPI team came down from CDC, they administered a KAB survey, and what we learned was that providers really weren't aware of the issue, didn't feel confident really addressing the issue. There was a general lack of information for them. So as you can see on the right, that's some of the educational material that was produced by the Arizona Department of Health Services. And so we were really fortunate that as this was evolving, you know, the proactive steps and the measures to start addressing this and start creating the educational material started flowing fairly fast. So we were able to access them and distribute them fairly quickly. So our case investigation and surveillance, again, it was a coordinated effort. So on the local end, what we did was we made sure we contacted the providers. We made sure we followed up with the families. We made sure we used our GIS surveillance, and we continued our clinical outreach. We did a series of public service announcements. We tried to find anything we could to, in the form of patient education material as well. We downloaded all sorts of stuff off the internet, the great site from the CDC as well as the Arizona State Health Department. And we started that cross-jurisdictional communication, again, with our partners. And again, really critical to this step was the Office of Border Health, so thank you so much. When the CDC EPI-A team came down, they enhanced those surveillance efforts greatly. They went out to houses and the clinically diagnosed cases, visited with the families, issued a risk assessment questionnaire to try to identify if perhaps there was more cases. They did field assessments to try to identify additional potential breeding grounds. And they did cluster investigations, so I believe it was a 50-foot radius from wherever a clinically diagnosed case was. So our public education and our outreach, again, was the key. So it was important for us to inform our local authorities. So when you're trying to do something of this measure and it's not on plans, funding is always an issue. So we had to be a little ahead of the game and tell them we might need to put some extra money into these issues. We're going to try to coordinate. We're going to try to do all these strategically aligned approaches, but we might have to redirect some funding to address this quickly. We took advantage of media messages, so we did Facebook, Twitter. We posted things on our county website. We have a county access channel that is produces a specific segment called Health Watch that is aired before every county board of supervisors meeting, and then it's looped through the county access channel. So we use that to inform the public of things that they needed to be aware of and how they could keep themselves safe, preventive measures, things to look for. Things like personal protection and, again, general disease information. So we knew the EPI team. We had worked that out. We had worked with the state. We had decided we're going to do this joint approach, and the CDC is coming down. this was right on the heels of the Ebola planning. And so the first thought was, we don't really want a whole bunch of CDC people in uniform running around our county, because that's going to spark all sorts of fear. So from a logistical standpoint, it was important for us to be able to get out in front of it and tell people, the CDC is coming, and this is why they're coming. So it wasn't just the CDC. The approach or the team that arrived, it was the Centers for Disease Control, it was key staff from the Arizona Department of Health Services, and it was also people from the University of Arizona who specialize in this area in vector control. So we went out, we went to the different media outlets. We made sure, because of our proximity with the border, to share that information in both English and Spanish. So we made sure that we did media interviews, newspaper articles, telling people that we were seeing some cases of dengue and that it was important that we be proactive. And because we wanted to be proactive and we wanted to take the best steps possible and the most effective proven strategies to protect the community, that we were going to be hosting a team composed of experts from the CDC, the University of Arizona, and the State Health Department. So what that did for us was, when they did show up and they actually knocked on doors, they were expected. And people actually wanted to help. So instead of having that feared response, why are you here? Why is the federal government knocking on my door? It was, what can we do? And living along the border, sometimes there's that basic distrust also of government agencies, let alone one that's going to show up in your door and start asking personal questions. So that actually was very useful for us. So again, because of our proximity to the border, everything had to be culturally and linguistically appropriate. And every time we released information, we had to make sure that it was available in both English and Spanish. So I do this all the time. So what did the community outreach look like? So there was a lot of door-to-door. There was a lot of organizational things where information was distributed through schools, information was distributed through the Parks and Recs departments, information was just distributed through the utility companies, and then again, we had volunteers go door to door. And so you can see this example of a bulletin that's produced by the Centers for Disease Control, and you could see how we packaged them as door hangers and went around, the different neighborhoods. So going back to the culturally appropriate issue, we, typically, especially when it's federally produced documentation, patient education documentation, it's generally available in English as well as Spanish. What we ran across is sometimes the Spanish is not, it's not the same Spanish that's used in that particular area. So in this case, again, our partners across the border in Sonora had produced some great material that was meant to be read by the population living across the border. So they were very gracious and let us borrow it. And so you can see these materials are from the Secretaria de Salud, and they were very gracious in allowing us to use that material and source it and put it on our websites, because that was one of the lessons. One of the lessons was we translated a lot of material, and if you ever wonder if people read what you're putting out there, I know they did in this case, because I got the phone calls. It's not mosquito, it's zancudo, it's, and so there was all these suggestions. So I know people were reading it because I was getting lots of voicemails. So then we just went with the obvious source, and the Office of Border Health was able to help us procure that information. So that was the education piece on my end that I wanted to share with you. And again, there's lots of challenges, but I think one of the big lessons that I learned from this was the importance, again, of that public health infrastructure and the ability to, as a rural county, sometimes you have challenges. We have one epidemiologist who does an amazing job, but it's just him. So being able to get that epi support and being able to get that technical assistance and being able to pick up the phone and just reach somebody at ADHS on the other end and know that they're going to be working on their desk. I swear I could call at any time and they're working. So it was really nice to have that access to that additional support, that those resources that you normally wouldn't have. So when you have a smaller health department, it's the same people, doing the investigation, collecting the data, doing the brochures, and those of you that come from a rural area probably can relate to that. So having access to that information was invaluable because it allowed us to focus on other aspects, primarily the coordination and the planning of the educational piece. But I'd like to hand it over to Richard, and he'll talk a little bit about the abatement of mosquito control that we did. Hopefully he'll be better at navigating.
Good afternoon. My name is Richard Cumming with the Yuma County Health Department, Vector Control Specialist. Been there for going on 23 years. My colleague Joey Martinez has also been there over 20 years. When we first discovered Aedes aegypti back in 2014 during the dengue epidemic, we asked the CDC to come down here and kind of give us some pointers on what to look for. So when they first showed up, we go out on their home visits and stuff, and we're looking for pools and buckets and stuff like that, and they're pointing out little caps of water and toys and stuff, and we quickly learned that this is a totally different animal than what we're used to. So, typically we go out in the backyard or something, we see pools and buckets and fountains and stuff. And that's usually what we're telling people with West Nile virus, get rid of all this stuff and everything. It's not the case with Aedes aegypti. Again, we're looking at toys, wagons, all these wheelbarrows, stuff that we didn't even think of. We wouldn't even think of. We just pass it over. If the water's going to dry up in a couple of days, there's not going to breed any mosquitoes. But because Aedes aegypti breeds a totally different way, you still got to worry about it. We also have to worry about stuff inside your home. Lucky bamboo, vases, plants, potted plants. They seem to love this stuff. This is actually, afraid to say, is my mom's house. She's 75 years old, and I still can't get to her. She needs to listen to me instead of the other way around. We also treat all the storm basins, and dog water dishes. We actually had one of our sanitarians bring in some mosquito larvae found in his water bowl. We reared them out, Aedes aegypti. Some other concerns is these are at our public library, the roots of the tree, and every time the sprinkler comes on, these would all fill little bitty buckets of water, and they're breeding Aedes aegypti. We've still got some flooded areas, and then we got our drainage basins in town and stuff. That's mostly our Culex issues. We did recently had a subdivision in town where all the yards of the houses are the actual flood control basins. And this is a newer subdivision. People pay big money for these houses. And they're calling around saying, I've got mosquitoes in my house, I've got mosquitoes outside, I'm getting bit below the knee. We go out there, set some traps out. We're catching Aedes aegypti, and I'm catching 10, 15, 20 in a CO2 trap. Do some site investigations, go throughout the house. There's no water. What we discovered was that each yard, I don't even see it here, but there's a little 4-inch piece of PVC pipe that runs from the front yard to the backyard. And there's another one here, still got some water in it. Well, these are designed to let the water into the backyard for additional storage. What they're doing is they're filling up with water because of your lawn irrigation, and they're perfect breeding sites for Aedes aegypti. Once we figure that out, we have to go through the neighborhood, we treat each pipe, inform the homeowner of what's going on, and we're trying to get them to put screens on them. A lot of people don't want to put screens on them because then they get plugged up, and take it one way or the other. This is something that you're going to have to do. We don't have the time or manpower to do this. We use integrated mosquito management. It's very important. You have to have surveillance. Without surveillance, you don't know what's out there. You don't know what type of mosquitoes you got out there. You don't know where they're at. You don't know what numbers they're at. Source reduction is our number one priority, is what we're doing in Yuma County, is to try to get rid of the mosquitoes. We are canvassing neighborhoods, especially now that we find Aedes aegypti in neighborhoods. As you saw earlier with the door hangers, we're setting them on each and every door. Very labor intensive. I'm not really built for walking, but his job has to be done. Adult and larval control, is we used to have a lot of green pools. We do. We went up. We're probably 200 to 300 a year. Not as nowhere near what Maricopa's dealing with. Back. Where'd it go? There we go. And then our community education. We've been giving a lot of talks to realtor associations. What is it like? Civics groups and stuff on Aedes aegypti and getting the word out. And then we've developed our mapping and our record keeping. We've been working with GIS for the last couple of years to map and locate any type of breeding site, what type of mosquito it is, what type of it's complaint, initial investigation, or follow-up or whatnot. The 3 traps that we're normally use is our CO2 trap, the BG Sentinel, and then our Spring Star trapping kill, which we've kind of modified thanks to Chris Sumner with the addition of a black solo cup on there with some sticky fly paper in there to hopefully catch the adult as she's leaving the trap. Whoops. Okay, so starting the process, you got to get all your traps ready. Is everybody here aware of the Spring Star trapping kill? What it is basically it's an oval trap, and you fill it full of water, and we use 2 to 3 hay pellets full of water to the trap. It's got a little felt strip inside there, and then as that water gets, and the little chemical strip to kill the adults. And we set these out throughout the neighborhoods looking for the eggs, and we service them weekly and bring those back into the health department and look them underneath the microscope. Placement's key. We try to put them in kind of dark areas, low to the ground, to get best placement for Aedes aegypti. We recently got some mason jars from the state to go ahead and do some more of the traps. We're going to take we're going to modify the great mosquito hunt. We're going to use the great Yuma County employee mosquito hunt. We're going to try to use our employees to give us some more manpower out in the field. Keep hitting the wrong button. Okay. Again, larviciding is a big part of ours. Control. We don't tend to use too much mosquitoes for fish anymore. We don't do too much adulticiding unless we actually need it. There are places around the river and stuff where we can't get to. Larviciding is just out of control. You can't do it. It's out of the question, so you have to do some adulticiding. We recently have acquired some new equipment. This is our backpack with a little handheld fogger, and then we got a new Cougar fogger. And then this is our GIS mapping, where we go ahead and map every complaint, and, whether it's a mosquito complaint, a fly complaint, if it's a breeding site, or if it's an Aedes aegypti, Culex. This gives us a view of where our mosquito activity is in our county. Again, that's just some of the examples of what we can record on there. Again, more details when we do our fogging. It logs everything: how much per ounce per acre, how much we put out, how many acres we sprayed, what chemical is, what time it is, exactly where we were spraying. And moving forward, we're going to train additional staff. We're looking into working with other departments, with their inspectors, letting them know what to look out for, giving them flyers they can actually hand out to homeowners. We're going to participate in more work groups and committees, which I really haven't been involved in a lot until the Zika hit. We're left and right now. We're looking at some internships and educational opportunities with the college. Again, to get some more additional resources for us. We are a 2-man team. We do have a couple of other agencies in the county that also do mosquito control, so we are very grateful for that. We do have a service request portal that we have put on our website where people can call up and or log into and actually file a formal complaint with us. We do a lot of community education. We're going to go with door hangers, TV spots, commercials, maybe even commercials before like movies, on the sides of buses, airports, anything we can do to get the word out that people are really going to be the key to help control Aedes aegypti. And then ongoing staff development and training. Any questions? Yes.
You had mentioned something important on the public information officer for Maricopa County Public Health, and one thing you mentioned that kind of struck right here is you talked about finding the mosquito indoors in those potted plants, which is, in terms of messaging, is something that we haven't heard before. Is that something you found a lot in when you were doing your?
We haven't found a lot of breeding indoors, but there have been a couple instances where we found them in some potted plants. Aedes aegypti seems to love the little dishes underneath there. I found a couple of the pet water dishes breeding, and it seems when people call up and complain that we've got mosquitoes, if they say they've got them inside their house, then it's probably 80 to 90% chance that is an Aedes aegypti mosquito that we're dealing with.
Usually would that be because they didn't have screens or anything in terms of a barrier of them getting into the house?
I really couldn't answer that. Probably, I mean, it's down in Yuma at this time of year, people love to leave their windows and doors open. And we need to get that message out that people need to have some screens. And
Let me add to that. Even if you find one mosquito, that one mosquito can turn into 100 tomorrow. So it's not a question of how much. It's do you have them or not? And if you do, eliminate it.